Okay, so hello everyone. My name is Brooklyn McIntyre, and today I am going to be discussing the reproductive system disease called polycystic ovarian syndrome, also known as PCOS. Oh. Okay, so background. Polycystic ovarian syndrome, also known as PCOS, is a hormonal condition that affects women of reproductive age and is often undiagnosed due to its various symptoms. Despite its name, however, not all women with PCOS actually have cysts on their ovaries. So, also with PCOS, additionally, women with PCOS often have elevated levels of androgens, male hormones, which can impact both their physical appearance and ovulation. This hormonal imbalance can further disrupt the normal functioning the normal functioning of the body and, of course, the ovaries. And worldwide, PCOS affects 6% to 10% of women, making it the most common endocrine disorder in a woman childbearing age. So, these are just some signs and symptoms. Of course, there's menstrual irregularities, infrequent, prolonged, or absences of a menstrual period. There is hyperandrogenism, excessive amounts of facial hair, body hair, acne, and male pattern baldness. There's also polycystic ovaries, enlarged ovaries containing multiple follicles, weight gain specifically in the abdomen. But there's also can be symptoms of eating disorders, including anorexia, bulimia, binge eating, or orders that are very common in women with PCOS. There's also a prevalence of type 2 diabetes with women that has PCOS, and there's also disturbances. It has been found for women with PCOS to be twice as sleep disturbances to be twice as common in women with PCOS compared to without. And then also another thing is women with PCOS may have difficulty breastfeeding and producing significant milk for their young, their babies. Now let's get into the etiology, also known as the causes. So first, of course, going back to genetics, family history increases risk of getting this disorder. Then also you have insulin resistance. Elevated insulin levels can increase androgen production, and of course, it is estimated that 50 to 70% of women with PCOS have insulin resistance. And then, of course, hormonal imbalances, elevated luteinizing hormone, LH, and decreased sex hormone binding globulin, sorry, I cannot talk, SHBG levels. Now, we're going to talk about the molecular mechanisms responsible. There are several molecular mechanisms contribute to the development of PCOS. As I said, the genetic factors, such as variants in genes like I hope I'm saying this right, but DENND1A have been shown to influence androgen biosynthesis. That is also additional changes in the microRNA, miRNA expression can disrupt normal processes like steroid hormone synthesis, follicular development, insulin signaling, abnormal activity of key sterogenous enzymes. So now the diagnosis and techniques. So the diagnosis of PCOS typically involves a combination of clinical evaluation, laboratory testing, and imaging. Clinicians assess symptoms such as like I said before, symptoms acne, irregular menstrual cycles, which may indicate in what's called indicate irregular hormonal imbalances. Blood tests are also often used to measure the hormone levels, including the luteinizing hormone. I mentioned the luteinizing hormone, but I don't believe I talked about what it is. So basically, it's for ovulation and helps with the hormone production needed to support pregnancy. And then, of course, the follicle stimulating hormone, FSH, that hormone helps control the menstrual cycle. It triggers the growth of eggs in the ovaries and gets the eggs ready for ovulation. So, and also testosterone, and of course, insulin. There's pelvic ultrasounds imaging is also performed to check for presence of polycystic ovaries. But remember, this cannot be the only technique because sometimes some women don't have polycystic ovary. What's it called? Don't have that. Not yeah. So there's also the Rotterdam criteria are commonly used to diagnose PCOS, requiring at least of the th- of two of the following three factors: infrequent or absence of ovulation, clinical and or biochemical signs of hyperandrogenism, and the presence of polycystic ovaries on ultrasounds. Whew. Now, getting into the current treatment. Managing PCOS is all about relieving symptoms and protecting long term health. So, what is the best way to be able to do this? Of course, is your lifestyle changes. If you want to have treatment for this, you're going to have to change your lifestyle because now this is a part of your life. So, losing even a small amount of weight through healthy eating and regular exercise can make a big difference by improving insulin sensitivity and balancing hormones. For example, eating protein and or fat containing foods every 3 to 5 hours throughout the day may help to stabilize blood sugar levels and prevent cravings in PCOS. And then also, regular exercise is an effective way to improve insulin levels in PCOS. Remember that because they have a high level of testosterone, well, androgen, there's also women with PCOS also have it's easier for them to build muscle and to grow muscle. So always one thing that I know a lot of people do is meal prepping. You can of course meal prep, have a schedule, have days where you go and work out and just have that mindset of I need to change my life. And then of course, if there comes a case when lifestyle shifts aren't enough, you can and you can do go through the medicational steps. There's, of course, your lifestyle medication, and there's also supplements that you can use for treatment. But back to the medication, hormonal birth control helps regulate periods and lower androgen levels. There's also metformin, often used for diabetes, and can tackle insulin resistance. Because remember, women who have PCOS do tend to have type 2 diabetes, and it also can happen during their pregnancies. So, as I was saying about pregnancies, if pregnancy is the goal, medications, I probably am not saying this right, but bear with me, like cleofenin or letrozole can help jumpstart ovulation. Remember, because of the irregularities with the menstrual cycle and ovulation, same thing. But there does happen the case where women with PCOS struggle with stillbirths, miscarriages, and infertility. And for stubborn acne or excessive hair, an androgen offer release. I also suggest going to a dermatologist for the acne preferences because they can also tell you a lot. So for those who don't respond to medication, there's even a surgical option. Basically, the best way that I can put this is a minimal invasive way to encourage the ovaries to function normally again by ovarian drilling. But that is some ways for current treatment. So these are my sources. Thank you everyone so much for listening to my presentation. Bye.